Hello, everyone, and welcome to tonight's event. So we're delighted to have with us Judy Wadsworth from the Daisy Garland. So we're going to be focused on ketogenic diets today. So for a number of people who live with epilepsy, the ketogenic diet can be of benefit to them. It has been shown in some cases to reduce seizure frequency and severity. One side thing just to be aware of before we start is we really reiterate to you to seek medical advice before going ahead with any changes to managing TSC related epilepsy or anything like that. So do please speak to your healthcare professional, most likely your neurologist, before you make any changes. We are recording this event, which you may well be aware due to the notification at the beginning when you logged in, and that's essentially everything. We're all really keen to hear from Judy, so I'll pass over to Judy nice and quickly now so we can get the most from the event. So over to you, Judy.
Thank you. Good evening, everybody. Thank you for joining this presentation about ketogenic diet therapy. I was just going to say a little bit about me. So I worked in the NHS for 36 years as a paediatric dietitian, and more recently I worked at the Children's Hospital in Oxford, and where I actually specialised in ketogenic diet therapy for children with complex epilepsy. I did retire from the NHS 18 months ago, but now I'm very honoured and pleased to be working with the Daisy Garland charity in supporting families who are actually already on the ketogenic diet therapy with my background as a dietitian. So this is Daisy. So the Daisy Garland charity was set up after little Daisy unfortunately died of her epilepsy. The charity was set up about 22 years ago by her parents, Sarah and David, who work incredibly hard, and they have a very small team down in Totnes in Devon, and they offer lots of guidance to the families and the children. They have funded many dietitians in NHS hospitals so that children can benefit from trialling the ketogenic diet when needed. They also do lots of other lovely things, and they can supply nighttime monitors. They have little projects that they do. They're doing a green shoots project at the moment where they send out little packets of seeds so that the children can actually try and grow all their fruit and vegetables. And yeah, so they're a nice little charity, but very small. So the topics I was going to cover in today's presentation, I was just going to talk a little bit about the history of the ketogenic diet, a little bit of science, if I can. There are different types of the ketogenic diet, so we'll talk about those. A little bit about diet planning, how a dietitian initiates the ketogenic diet, and talk about monitoring, because there's various things that need to be looked at the beginning of going on the diet and throughout the course of being on the diet. And then I was going to talk a little bit about how we manage illness. So the ketogenic diet has actually been used as a dietary management for epilepsy since the 1930s. So it's been around a long time. And over the years, I think it's fair to say it's waxed and waned in its popularity. In the early days, it was considered a breakthrough, and it was sort of used by consultants and when medications weren't working. And then there was sort of like an influx of new medications to treat epilepsy, and the diet did sort of fall off in its popularity a little bit. But the reason why the diet came about was that it was noticed that there was seizure improvement in patients where when they were fasted, and that was back in 1911. So obviously you can't fast patients all the time. So it was like, well, how can we mimic this fasting metabolically? And the original diet was designed to copy, if you like, starvation. So when the body is starved, then the body will draw on the energy reserves of body fat, whereas usually it'll be using carbohydrate from the foods that we eat. And then skeletal muscle and other tissues switch the energy source from glucose to free fatty acids. And then you get an increase in the oxidation of fatty acids in the liver, resulting in an increase of ketone bodies, namely acetoacetate and beta hydroxybutyrate. And then these ketone bodies will be used as a fuel by many tissues, but most notably in the brain. So the scientist was called Wilder, and in 1921, Wilder suggested this diet, which basically is very, very high in fat and very, very low in carbohydrate, and this mimics fasting. So the original diet by Wilder used only 10 to 15 grams of carbohydrate, and then 1 gram of protein per kilogram body weight, and then the remaining energy would be coming from fat. Now, back in the day, the fat was all natural fat. It was just butter, lard, and cream. So it wasn't the most palatable diet back in the early days by any means. And he introduced the term the ketogenic ratio in the classical diet, which basically describes the ratio of fat to protein and carbohydrate in the diet, which we'll talk about in a little bit more. So as I mentioned before, there are different types of the ketogenic diet, different versions of it. The classical, which uses the ratios that I've mentioned. There's the MCT version, which is called the medium chain triglyceride diet. Quite a lot of centers are now using what we call the modified ketogenic diet, which again, I'll focus on in a little bit. And there is another version of the diet called the low glycemic index treatment, but this isn't really very effective. And it might be in some adults, this might be the chosen one, but in children, we very rarely use the low glycemic index treatment. So I just wanted to sort of compare and contrast really where the energy comes from in a typical UK diet, where the energy comes from when you're on the highest form of the classical ketogenic diet. So in the UK, about 50% of the energy in the food that we eat comes from carbohydrate foods. So that's things like cereals, bread, pasta, rice, potatoes, and cakes and biscuits. So a big percentage of our energy will come from carbohydrate foods. And then about 35% of our energy comes from fat sources, which could be, the fat on a piece of meat, or oils, or the butter we put on our bread. And then 15% will be coming from protein, obviously your meat, fish, eggs, cheese. So that's what our sort of typical UK diet will look like in the pie chart anyway. And then if they were on a classical 4-to-1 ketogenic diet, 90% of the energy is coming from fat, which is obviously very, very different. And only 4% will be coming from carbohydrate foods and 6% from protein. They're a little bit different if you're on the MCT diet or the modified diet. So the percentages change just a little bit. On the MCT diet, you can have a little bit more energy coming from your carbohydrate foods. And this is because the MCT fats give a slightly higher yield of ketones than ordinary fat. So 73% of the energy comes from fat in this diet, 10% from protein and 17% from carbohydrate. For those on the modified diet, then they have a really restricted carbohydrate intake again, only about 5%. And then 65% will come from fat and 30% will come from proteins. So a lot more liberal protein intake on the modified. And we would usually probably use the modified in the older child or the teenager, or you know, the ketogenic diet is used in some adult centres as well. So how does the diet work? This is a sort of sciencey bit, really. It might be that the ketones themselves, when they're produced, have a direct anticonvulsant effect, which is in the brain. So this is a sort of simplistic approach. Or, as I talked about, you get a higher level of free fatty acids in the body. Is this actually dampening down seizure activity in the brain? When you're on a very high fat diet and a low carbohydrate diet, then you have low levels of glucose in your bloodstream. That will lower insulin production and increases leptin, which has an anticonvulsant effect. Another thought is that it's the altered neurotransmitter function, because there are increased levels of something called GABA, which basically is a chemical messenger in the brain that has a calming effect, and is thought to sort of decrease the sort of seizure activity in the brain. There's been some more recent work looking at the actual mechanism of medium chain triglyceride fats, namely C8 and C10. And I'll talk about a new product that's been developed following the research that was done. And C10 has a very positive effect on seizure activity in the brain, and C8 sort of enhances the amount of C10 that is in the brain. So that's quite interesting work that's come out. So when do we use the diet? So we know that 20 to 30% of children with epilepsy won't respond to their anti-epileptic medications, which is obviously, you know, significantly higher number. And NICE guidelines were written, which suggests at this point these children should be referred to a specialist neurologist in a specialist centre. And obviously, when they are referred into a specialist centre, then the neurologists, you know, will probably try more of the anti-epileptic medications to start with. And unfortunately, you know, some children, you know, may be on 2, 3, 4 medications trying to control their epilepsy, and they don't respond. So it's suggested that diet therapy might be considered at this point. There are other therapies that might be considered as well, which you might have heard of: vagal nerval stimulation, or extreme cases, resective epilepsy surgery. How do we know that the diet actually is effective? Well, obviously, there's been 100 years of you know, children trying the diet, and so lots of statistics and evidence and anecdotal reports that the diet is effective. And so of all the children that are referred for a trial of the ketogenic diet, about 15% of children will become seizure free. So obviously the children really that are referred for a ketogenic diet have tried lots and lots of medications, still having horrible seizures, frequent and prolonged, and end up in and out of hospital. And so the diet is offered, and so that's you know, when children are put on the diet, when they have such troublesome epilepsy, it's just amazing that you can still, you know, get seizure freedom from trialing the diet. There's also about 20% will see an 80 to 90% reduction in seizures, and another 20% of children will get a 50 to 90% reduction. So that's over half of the children that will be referred for ketogenic diet therapy who have complex drug-resistant epilepsy will get some benefit. There will, of course, then be sort of others that it doesn't work for, but we can't predict at the moment who's going to benefit and who's not. There are certain conditions and causes and diagnoses that we know the diet is more successful in managing those seizures, but yeah. So the children have seen the consultant pediatric neurologist in the specialist centre. They've probably tried a few medications, and if there's fortunate to be a dietitian in the centre, and again, that's obviously we're few and far between really still. I don't think there's ever enough dietitians to try the diet, offer the treatment, the diet treatment that we would like. Lots and lots of hospitals unfortunately do have waiting lists, and yeah, sometimes they have to wait a couple of years before maybe they can try the diet. So anyway, the neurologist will refer into the dietitian's service. We would do a dietetic assessment to find out what the child was eating, get an idea of what their calorie intake was like. We would need to do some bloods before the diet was considered. We call these baseline bloods. And we would be looking at renal function, kidney function. We look at all the fats that are in the blood. We look at trace minerals. We look at vitamin D, just to make sure that the diet is safe to start. There are certain metabolic conditions where, if they were picked up on these initial blood tests, we wouldn't be allowed to start the diet, and sort of fatty acid oxidation defects and familial hyperlipidemia, all big names, but these things will be picked up on those blood tests, and we wouldn't be able to use this particular diet in those conditions. And the bloods would also pick up if there are any deficiencies. So it's not uncommon for children to be vitamin D deficient. So we would correct that before the diet was started if needed to be. And then children obviously grow and gain weight. And despite going on to the diet, we still need to monitor all this. So we get a baseline weight and height to check that they'll continue to grow and thrive when they're on the diet. So preparing for the dietary treatment, as dietitians, we would obviously have a look at if there are any behavioural feeding difficulties. Is there any food aversions? Do they dislike things? Are they, do they feed well? All those sorts of things. I'm not saying that, we would still be able to start the diet, but it's important to have all these facts before and get to know the family and the child. Dysphagia, obviously, in children who have sort of complex needs, then there might be swallowing difficulties, and hence when we're thinking about the diet, we need to think, do we need to modify the texture? Does it need to be smooth? So we would establish that. Again, in children who have very complex needs, quite often gastroesophageal reflux is a problem, and constipation could be a problem. So again, because the diet is very, very high in fat, then you get a delayed emptying of the food from the stomach. So these conditions could be aggravated. So we need to know about them from the beginning so that we manage them appropriately when they do start the diet, so that we can keep on top of those things. We need to know whether the child can eat orally, or whether they're being enterally fed. So enterally fed, I mean sort of with a tube that goes into the tummy called a gastrostomy, or some of them might be on a nasogastric tube, which the tube goes into the tummy. Again, it doesn't stop them from trying the diet, but it would obviously affect how we plan the diet for the children. And food allergies, I'm sure, you know that lots of children do have food allergies, cow's milk protein being the most obvious. So again, we would have to decide on different types of food. come up with, the appropriate diet for the children who have an allergy. Just take a sip of water. So pre-diet planning, the dietitian would need to establish what the child was currently eating. So we would ask them to do a food diary for 3 or 4 days, and then we would calculate that out. And we would then compare that with there are recommended energy intakes for children at different ages, and we'd compare and we decide how many calories the child would need when we're calculating out the diet. Protein requirements. Protein is important, obviously, and you'd need the minimum amount of protein for growth. So we would work that out based on their age and their weight. And then we would have a discussion about which diet. Within the UK, I think different centres do have different preferences for which version of the diet they use, where they have the most experience, where they have the most success. It would always be my approach to sit down with the families and explain the different diets and have a think about which might suit the family best. And we'd come to that decision together. So when we're thinking about starting the diet, we do explain that there are various timeframes that we'd be looking at. And initially we'd say, okay, from the start of the diet to the first review, we would say that would take 3 months. So we'd do a 3-month review after and trying to establish, are the family coping with the diet? Is the child coping with the diet? What effect, is there seizure on the seizures? Is the diet having? How successful? And come to a joint decision really about, is the diet worth continuing or not? And then the 2 years on the ketogenic diet, sometimes, this causes a few problems. But again, it's a time frame. Some children stay on the diet for a long time, but 2 years we would come together again and assess the efficacy of the diet and how everyone's coping. For some children that I've looked after, the fact that they can't have ordinary chocolate for 2 years is the deciding factor about, trying to wean them off. But okay, so just looking at the diets in a little bit more detail. So the classical, I would say there's a lot more experience because it was one of the original diets. It would definitely be one that we would use if a child was needing enteral feeding via gastrostomy. It's a very strict prescription. The meals look really, really small when they're prepared because there's a lot more calories come from fat than they do from carbohydrate and protein. So that means the meals are very small when they're presented to the child. Yes, they're very restrictive in carbohydrate and protein. We would, as dietitians, give them some meals and snacks, which they have to weigh out all the ingredients really accurately. We would start at what we call a low ratio with the classical diet, a 1-to-1 or a 2-to-1, and then gradually build it up until we thought that the child was producing good ketones, and hence we knew that the diet was working maximally to try and control the seizures. The MCT diet, we call it, medium chain triglyceride diet. As I mentioned before, the MCT fats will give a higher ketone yield than a long chain fat. And so this would mean that the child could be having more carbohydrate. This can be sometimes good for the younger child if they like cow's milk, for instance, whereas very often on the classical, cow's milk's excluded. So for some families, this would work best for them. The slight negative thing is that medium chain triglyceride fats can cause gastro side effects. So they might get a bit more nausea, or they might end up with a bit of diarrhea, which can sometimes then mean that it takes longer for the diet to be introduced, and hence see the positive effects. The modified diet is a moderate protein intake, and the carbohydrate, as I say, is restricted to 10 to 20 grams per day, which is very, very low. We would provide families with lists of carbohydrate and fat portions, and they would sort of make up their own recipes and their own meals and snacks using these sort of exchange swap lists for carbohydrate and fat. So as a dietitian, I would offer the choices, sit down with the families and see what we think would work best. Give you an example of what fat choices are for the families, natural fat choices. So things like Hellmann's mayonnaise, 13 grams, which is probably about 2 teaspoons of mayonnaise would give you 10 grams of fat. Vegetable oils are pure fat, so 10 grams of vegetable oil will give you 10 grams of fat. 12 grams of butter would give you 10 grams of fat, and double cream, 21 grams. And these would all be weighed and measured very accurately for most of the diets. And then over the years, a lot of companies have sort of come to learn that the ketogenic diet is successful in managing epilepsy. And I guess with two schools of thoughts, they're sort of, this is a good product, and we're going to get some benefit in terms of monetary side of it, but also the companies tend to be very supportive of wanting to provide products that make the diet easier for the child to take or the family to manage. So a few of the companies here, Nutricia as a company that make Keto Cal in a powder form and a liquid form. The powdered form can be used to bake products with, and the liquid can be used to make milkshakes, and they're nutritionally complete, so they have added vitamins and minerals. Or the liquids would also be used as a base for any tube feeding that's needed. And then you've got nutritionals make things like Protifar, which is a protein source, Maxidil is a carbohydrate source, and collagen is a fat source. And these would very much be the ingredients that dietitians would use if we did need to design a tube feed that was going to go down a gastrostomy or a nasogastric tube. So they were probably one of the first companies that came up with ketogenic supplements that are available on prescription through the NHS. VitaFlow is another company who work very closely with dietitians and parents in trying to come up with products that are very palatable. So K.Yo, these little pots here, they do them in a chocolate and vanilla flavor, and they're like a little mousse. They're in a 3-to-1 ratio, and lovely, very palatable, and very, very useful part of the diet. And they also make the little liquid 3-to-1 K-Flow, which again can be used as part of a feed, or you can add flavorings to it to make like a milkshake. Another company called Cambrook, they're sort of come onto the market within the last sort of year or so, and again they're a competitor in terms of making a liquid 4-to-1 supplement that can be used either as a milkshake or as part of a feed. And then there are some MCT supplements again that are available on prescription if the MCT was the diet that the child was going to be on. So you get Liquigen, which is an emulsion of MCT fats in water. You get pure MCT oil, which can be used for frying and adding into meals. MCT Procal is a powder which lots of chefs will be using to make very nice ketogenic food. And K-Cook again is an MCT sort of emulsion made by VitaFlow. I mentioned before that there was some quite recent research looking at the effect of MCT fats, notably of the chain link C10 and C8. And this product, K.Vita, is only been available on prescription within the last 6 to 9 months, I think, to the point that I actually haven't used it because, as I explained, I'm not actually in clinical practice any longer. So it's quite an exciting product. It's a flavored MCT that's quite a sort of a thick fluid, and the idea is that you have this supplement with each of 3 meals, and it's built up really, really slowly because of the MCT aspect of it, but it's allowing the child to actually not go on a full ketogenic diet. They can just go on a low sugar diet, so slightly easier for families to manage. So as I say, obviously the trial showed that it was very successful in reducing seizure activity in some children, and it's now available through the NHS on prescription and is sort of being used quite successfully by different centres. When you restrict carbohydrates and protein and have a very high fat intake, then obviously you're missing out on lots of natural foods, including fruits and bread and things like that. So it's vitally important that all the ketogenic diets are supplemented with complete vitamin and mineral preparations. And there are 2 that are keto friendly and prescribed, FlexiBits by Nutrition and FruityBits by VitaFlow. Neither are that palatable, and children do sometimes struggle to take them. But there's various little ways that we can try and encourage them and flavor them and offer rewards. But you shouldn't be on a ketogenic diet without having a complete vitamin and mineral supplement. So again, the whole knowledge and understanding and desire to make the diet easier for children and families to follow. Companies are coming up with lots of new foods that they can get on prescription. So a company called Keto Care, they have designed all their foods are in the 3-to-1 ratio, so fit with the classical diet, but they can be used with the other diets as well. So they do a porridge and they do a muesli. They do what we call a biscuit, which is pictured here. They do a little bar that's sort of like a coconutty Rice Krispie bar. And then they do a couple of ready meals. One is a bolognese flavour and one was a chicken flavour. And so these are really useful if families are going on holiday or travelling, or maybe some schools might allow these to be warmed up in school and used, because so they're very effective. There is a rather nice chocolate alternative. It's an MCT base, and the Canzo company. It's a cocoa bar and it's very tasty actually. So that's can be prescribed for children, and obviously can be offered maybe as a treat at the end of their meal, and it's very popular. More recently, Cambrook have come out with what they call this quick mix, which is a great sort of powdered mix, and they provide lots of recipes, and you can make lovely muffins and tarts and things like that with it. Again, just helping families who maybe are struggling to come up with ideas for foods and meals and snacks. And then there are lots of low carbohydrate foods in the supermarkets, and I'm sure lots of you, even before you heard about the ketogenic diet, it's quite trendy, isn't it, to have cauliflower rice, and spiralized courgettes or something, and celeriac mash. Who'd have thought really that celeriac mash would end up on the on your menu of your posh exclusive restaurant? But it's a very low carbohydrate replacement for potato, which is ideal for children and adults who are on the ketogenic diet. So these are fantastic that they're so trendy. But then there's also companies making things like noodles and pasta. They're called slim pasta and bare naked noodles, and these are designed because they aid people who are on a low calorie diet, because they virtually have nothing in them. They're made from something called konjac flour, and again, perfect for children who are on a low carbohydrate, high fat ketogenic diet. So these can be bought in the supermarkets in Holland Barrett. You can get low carbohydrate breads, which are very, very useful, to make a sandwich. And bread, as we know, is very high in carbohydrates. So these are very useful adjuncts. And then things like, this is an example of an icing sugar. So, you can make a ketogenic cake, and then you can ice it quite freely with something, a low carbohydrate icing sugar. So yeah, the diet gets easier to manage as the years go by. These are some of the meals that some of the families within the Daisy Garland charity have posted over the years. So you can let's start at the left. If you're on a modified, obviously you have a bit more protein, so you can have sort of things like a pure protein sausage and egg, and then you have your salad bits on the side with your mayonnaise to give you your fat, and things like certain vegetables that absorb fat really, really well. So courgettes and aubergines, they absorb fat very, so they're a great adjunct to a diet. In the middle on the top, you have waffles. So you can make very, very nice waffles with ketogenic flours or almond flour, and then sort of a few slices of strawberry. You can make a pizza, again, either using something like an almond flour or using the prescribed products that I've mentioned already, the MCT Pro-Cal and the Keto powders. And then you can do a little roast dinner, replacing, as I say, potatoes, maybe with roasted celeriac, a bit of chicken, and some low carb vegetables. So very, very appetizing meals can be produced on the ketogenic diet now. And before COVID, I look a bit younger there, but we used to do cookery sessions where Derek is still a chef that works, I get it right, for Nutricia, and he used to come out, and we used to hire out a kitchen and teach our mums how to make different carbohydrate meals, which was really good fun. And then since COVID, it's all gone online, and he does Zoom presentations now. And then VitaFlow have Chef Neil, who does the same thing, and they actually, now tour around the country and abroad and everything, demonstrating how to make delicious ketogenic meals. Monitoring. So it's very important that we measure ketones when the children start the diet, and they have to do it twice daily in the beginning, and involves doing a little finger prick and having a little home meter that will measure ketones. And this is the most accurate way, and we have targets for the ketones so that we know that the body's using fat as its energy source rather than carbohydrates. And when the numbers are hitting sort of 2 to 5.5, 3 is quite high, but 2 would be fine, then we know that the diet is being used optimally by the body. You can look at urine using keto sticks. This will measure sort of ECC2 acetate. And again, there's some targets that we aim for to know that the diet is working maximally. In the longer term, as I mentioned before, the children need to grow, so we would always monitor their growth sort of every 3 to 6 months, depending on their age, and make any adjustments to the diet that needed to happen. The bloods are repeated 3 months after being on the diet to see if there's been any changes, if there's any problems. And then after that, the children do have 6 monthly blood tests, not necessarily all of the ones at the beginning. But yeah, so it's important that they happen. And then there is a slight risk of kidney stones developing if the diets continue for too long. So there are annual renal scans, ultrasounds to check that there's nothing going on there that doesn't need managing. So just briefly look at some further issues that we think about when the children are on the diet. We have to think about different medicines, a little bit about illness, and just briefly sort of what happens in surgery. So when you're on such a low carbohydrate diet, even medications can provide, especially children's medications, because obviously they tend to be syrups and elixirs or chewable tablets, which have lots of carbohydrate in them. So medications ideally should be sugar-free and sorbitol-free. And the lowest carbohydrate form of medications is usually in a tablet preparation. So that's something we would always stress to families when they're going to start the diet. Basically, because anything that ends in O's or ol can be converted to glucose, which, as I say, can affect the ketone levels. And then suppositories we know are okay, so that's fine. And then emergency medications such as the buccal, midazolam is suitable as well. So we just point these things out when the children are starting the diet. In illness, we again have to sort of explain that ketone levels might drop and possibly seizures may worsen. I mean, it should only be for a short term, hopefully, and it's very difficult to counteract that with the diet, but we just need to explain that. A very big thing that we do stress is that if a child did go into hospital and they needed any intravenous fluids, then you can't use dextrose, because this would immediately obviously supply the body with carbohydrate and could result in seizures. So we say that they need to use normal saline. This is, for some doctors from local hospitals, this goes against the grain of all their teaching and education. So we do suggest that children have sort of like a sheet that they can take in with them to hospitals to sort of explain why they can't have IV dextrose. And we would just increase the frequency of monitoring their blood glucose and ketones to make sure that everything was safe. Just briefly looking at surgery. So if a child is on a ketogenic diet and they need surgery for other things, it needs to be a team approach. So the ketogenic team would need to be discussing with the surgeons, advising them that need to take some bloods before they had an anaesthetic, looking at glucose and ketones especially. And again, just reinforcing that if they did need any intravenous fluids, they should be saline and not the usual dextrose. So just in summary, ketogenic diet therapy has a very clear place in the management of refractory epilepsy. And the guidelines say when 2 or more anti-epileptic medications have failed, this should be something that's offered to families and children. Thank you for listening. I hope you've learned some things, and if anybody does have any questions, then please ask away, or maybe you can message your team. But yeah, thank you.
Thank you, Judy. It's really, really interesting. So I've noted down a number of questions, and whether we're quite We have a little bit of time. Anyways, let's see. Well, first of all, we've got a question from Marie in the chat. So she's apologised because she can't have her mic or her camera on, which is absolutely no problem at all, Marie. So she has asked, I'm just wondering if there are any centres or services in Wales that support adults wanting to try the keto diet. And she's also asked as well, other than the sugar aspect, does the diet have any known contraindications with AEDs?
So the adult services generally in the UK are quite poor. There are a few centres that do offer ketogenic diet therapy. London, Sheffield, and believe Bristol. I'm not sure about, but compared with children's services, the adult sort of services are very poor, unfortunately. And I believe Wales is less fortunate as well, even for children's services. So yeah, I can't offer any answers to that one. What was the second bit of the question?
Yeah, no problem. So your best bet, Marie, likely would be to speak to the Cardiff clinic if you're in touch with them, or indeed we can do that on your behalf as well, and we'll follow up with you accordingly. The other question was, other than the sugar aspect, does the diet have any known contraindications with AEDs?
No, you can. As I explained earlier, quite often the children come to us and they can be on 3 or 4 medications. So, and that actually one of the things that we would work towards would be if the child or the adult was started on a ketogenic diet, one of our aims might be to reduce the AEDs that they were on, because as you know, there's lots of horrible side effects to being on lots of them. And yeah, so the answer is no. You can use the diet with any AEDs and hopefully maybe reduce some of the drugs that you're on, and just we have when I was working clinically, we had situations where the diet was so beneficial that all the drugs were weaned off over time, and they were just left on the ketogenic diet, and yeah, children benefited a lot from that.
Thank you. A few questions I have, and if there are any more questions, please put them in the chat as well. So you mentioned there about the dextrose possibly creating a situation where someone may risk having a seizure. I might be overthinking this. Does it create any sort of, does being on the ketogenic diet sort of increase any sort of sensitivities to, if you were to stop the ketogenic diet and go back to your regular diet, is there any additional risks to that because you're then reintroducing carbohydrates or whatnot? Or does it sort of just revert to what you would have been at, say, 6 months before?
So if the ketogenic diet has been successful in reducing seizures and the child's been on the diet for a long time, months, years, then, you would need to wean the child off the diet very slowly, just like you would wean, any AED off very slowly. And so you do that in a controlled way, working with the dietitian and the family, and it could take sort of a few months to wean a child back onto a normal diet. And obviously, if there's any points at which seizures escalated again, then he might stop at that point and slow down the wean. And so when I mean wean, I mean you are gradually introducing carbohydrate and reducing fat. So it's done very slowly.
Thank you. I have more questions. So a lot of people who have TSC can have problems with the kidneys, in particular when they get older. It tends to be the older someone gets, more into adulthood, it creates problems with the kidneys. My understanding, and it may not be completely right, but it's that the ketogenic diet can be quite harsh on the kidneys. Is that the case, or is it worth keeping in mind, do you think?
So when you're using fat as your energy source and you're producing ketones, and the urine potentially is a bit sort of acidic, which yes, isn't that's why there's a very, very low risk of developing stones, kidney stones, which is what we're monitoring for. And you can, encouraging lots of fluid is one thing that we would do. So you're sort of always producing dilute urine. So I didn't really mention that, but yes, when you're on the diet, we would encourage a high fluid intake, and there are some drugs that you can, if a child was sort of demonstrating any signs of sort of kidney stones developing, there are some medications that you could use to try and sort of alkalize the urine and make it better. That's so I don't know in terms of tuberous sclerosis whether I wouldn't have enough knowledge to sort of say, but it's something that we part of our monitoring would be looking at kidney function.
Thank you, that makes sense. One more question from me. So the potential reduction in seizure frequency was quite notable. I thought on the slide we showed earlier, it was certainly notable. I was wondering if that reduction lasts, because we know that it tends to be with epilepsy that you get that reduction, and then X number of months, a year, you kind of go up again, and then you start a different medicine, and sort of the cycle goes on again. So I was curious to see if that is something that happens with the diet, or if it's more sort of once you have those reductions, it tends to be a bit more long term.
I think that's quite individual. I think if you get seizure freedom on the diet, then that's pretty long standing and can last a long time. When you just get a reduction, however much that is, I think it's the same as with like you say, drugs. You can go up and down in terms of seizure frequency and intensity. There's a sense about having the diet there as in the background, though. There's a lot of not just seizure, it's sort of cognition, and especially for children, sort of their alertness and their ability to learn. And a lot of families will say that when children are really young, speech can come on, and the learning comes on, and just their function improves. So, and that, obviously that will continue, as well. So sometimes it's not just seizure management, it's those other things as well that the diet seems to sort of, aid and improve. but yes, you know, there, you know, you still get ups and downs, and you know, there's different events, aren't there? And there'll be different triggers for seizures still, even though the diet is said to be effective, you know, whether that's heat or whether it's anxiety or whether it's you know, puberty, you know, obviously, you know, comes along. So yeah,
Great, that makes perfect sense. Thank you. That's all my questions. You'll be glad to hear. Does anyone else have any more? I'm aware of the time, but I'll give it a few seconds just in case there are any final ones from anyone. No? All good?
I mean, I guess if, you know, we're in contact, aren't we? That I suppose if anybody you know, ask you questions, you know, outside of this time, then, you know, I'm happy for you to, you know, email me or whatever to see if I can help, or the Daisy Garland charity if there are other things that people want to know.
Great.
I think
Thank you.
There we go. There was there was one last one. That, yeah, the Daisy Garland website, and yeah, they're happy to email Nikki at the Daisy Garland charity as well, if anybody wants to have any direct contact with the charity.
Absolutely, we certainly do. We're always very happy to signpost people to the Daisy Garland, as we do very often on the TSC support line. Yes, that's everything, I think. So thank you very much, Judy. You absolutely learned a lot. No doubt other people have as well. So yeah, everyone, please keep an eye out for future events that are coming thick and fast. And yeah, just hope you've all enjoyed it. So thank you, everyone. Bye bye.
Okay, thank you. Bye-bye.
Bye bye.
Bye.